Thanks for having me and inviting me to do this lecture called the Trauma Tracer. So I'm assuming that we have a fair distribution of nursing staff, maybe some APPs, and maybe some EMS, ED EMS personnel here. So I have hopefully geared our lecture so that everyone can get something really basic out of the care for these patients. So for the disclosures, my disclosures are, as she mentioned, just related to the clinical trials that we're involved with. And again, I don't receive any personal financial supplements, nor do I have any other fun things that I get from them. So today's objectives. The learner will discuss the initial evaluation and core concepts important to the initial assessment of a patient with thermal injuries. We hope that you'll also be able to discuss some of the reasons for decontamination and also understand what our university workflow is. We will prioritize injuries in relation to thermal injuries, so we'll think about it from the trauma patient, but then have the caveat, well, let's think about this from the burn patient perspective. We're going to, of course, go through some discussion about fluid resuscitation, recognize some common complications, and then discuss some of the pathophysiology of burn injury, inhalation injury, and its impact on the continuum of care. We'll also include some things like temperature management and its physiologic impact. And then hopefully we'll do some verbal understanding, or hopefully you'll have some, be able to verbalize understanding of the anatomic and physiologic differences between our adult and peds patients, only for some acute reasons. And then identify treatment strategies and anticipate some of the post-burn complications during the first 72 hours of care. I know I've seen some faces out there and names that look very familiar to me, so even some who have moved on to the ED, so thanks for joining. And also you can put comments in when I'm wrong as well. Moving along. So just to remind you, we are the one of 78 verified burn centers across the entire U.S. We do serve a huge catchment area, includes Montana, Idaho, Wyoming, parts of Nevada, Oregon, and plus the full state of Utah. We are taking care of all types of burn injuries, including cold injuries. We also care for skin conditions such as TEN, SJS, and we also care for necrotizing infections and other soft tissue infections. We have an interdisciplinary team approach to care, and this is how every single burn center works. There is an article from 2009 where they really just laid it all out there. The only way to deliver the best care for burn patients, it requires an interdisciplinary team to make it happen. So that includes a nutritionist, a pharmacist, a social work / counselor, and psychologist, our respiratory therapist. So pretty much every part of the team has a direct impact on the care of our burn patients, and that's what makes us better at care. So before that, when we were just going to, whatever trauma center, patients were having poorer outcomes, and they have studied this and shown that with this interdisciplinary approach to care, that we have improved by almost 90 to 100% the potential for people to survive burn injury. So this is really important. And all people, when we think about this, anyone in the pre-hospital space and the ED, you all have an impact on the ongoing survival of that patient. And if we don't get it right at the beginning, we actually aren't able to do much on the end. So this is a very important lecture from my perspective in general. So there we are. Here's some just national statistics. We have about 450,000 people with burns who visit the ED per year. About 45,000 of those will be admitted to any hospital type, and about 20,000 of those are admitted to specialized burn centers. Just so you know, there's only 1,900 burn beds nationwide. That's it. That actually includes non-verified burn centers. So we still have a lack of resources to support, just the minimal 20,000 cases we see per year in the units. 96% survival rate is expected for most patients. As you get older or super young or really huge burns, that becomes a little bit challenging. Here's the distribution of ages and gender and the type, the distribution of burn injury. And as you can tell, in your 20s to 50s is when we see the most, and also men seem to take up most of this. So usually 75%, 60 to 75% of our patients are male, and it's during their productive years, or we see that it's mostly in that younger age group between the 2 to 5-year-olds. And here's a way that we kind of assess your potential for having complications or dying, actually. This is a graph of the percent of patients that died along the axis here, the y-axis, and along the x-axis we have the Bow score, which is the age plus their burn size. So as you start to get a number greater than 100, you're getting to 50% mortality. And that is really significant because you oftentimes have patients who are over that, and it's hard to have these conversations, but they have an increased risk for dying. And so we have to have very hard conversations. Even if they're kiddos, we have to have hard conversations about what our goals are and what the potential survival is. And this is just age and just your burn size. It doesn't include any of the other comorbidities or other things that you come with before you even have your burn injury. So just something to keep in mind and understand, because most people don't get to have this much granular understanding of how the burn impacts the person. And it's actually a dose-based response. So if you can see, as your age gets bigger and also as the burn size gets bigger, there's almost like a dose response of impact on the physiology and potential for death. So let's talk about the initial management. Let's talk about the first 10 minutes. And I want to make sure that everyone's mind is really geared towards the acute trauma patient. If you've had acute burn life support as well, training, then this is probably going to be very similar. And that's where we always start, is with ATLS. That is going to trump, any traumas are going to trump everything else, and we still manage and treat and evaluate in the same exact way. So we're going to talk about this more so, though, from the burn perspective. So for the primary survey, it's all still the same. Adjunct, secondary survey are pretty similar. There are just some extra caveats that we have to think about within that space. So let's talk about airway. When it comes to airway, and we're thinking of it from the burn perspective, first, with all of these, just make sure there's no active trauma as we're moving through them, because these may be concomitant with the burn injury. So is the airway patent? Yes or no? That's a pretty simple question that you have to get answered. If it's not patent, then you intubate, right? Is the patient able to protect their airway? If they're not, then again, you put in a breathing tube. Now here's a little bit more related to kind of the burn issue. Is inhalation injury suspected, yes or no? So if inhalation injury is suspected, we have a little waffle room. Not everyone is going to need intubation just because you have inhalation injury alone. So we'll leave that on the back burner for now. Does the patient have facial burns and edema? Yes. This is also another space where we think about, well, this might be an indication for intubation for this patient, especially if they're having signs of stridor or distress from a respiratory standpoint. Is the burn larger than 20%? Yes. This is the patient that we are probably going to ask you to put a breathing tube in. And if you think about this in the pre-hospital setting, at the scene, these are what we call the walking wounded. You can actually have a 90% TBSA burn and still be able to have a normal GCS and be walking around at the scene. And, you know, those are the patients who kind of get overlooked and get a little bit missed. So it's important to understand how burn physiology eventually will impact our patients. So what happens with a burn over 20%, you get more surface area of burn injury. This now transitions into a systemic inflammatory shock state. And you get edema and swelling in all of the tissues, including and specifically the airway. So if those things are true, then, you know, based on how the patient's doing clinically, we would strongly suggest and recommend you intubate. We'll probably just say for anyone who has a burn size of 30% or greater, automatic intubation. And they don't have to have facial burns, and they don't have to have inhalation injury. It's just the burn itself. So let's take a little detour for the airway, and this is where we talk about some of the adult and pediatric differences. So it's important to understand that the pediatric airway and the adult airway are different, and they vary. The adult airway is pretty cylindrical. It doesn't have very many tight spots throughout, so you're less likely to have issues with a lot of swelling from the soft tissue. Whereas kiddos, they do have a bigger tongue. They have a harder epiglottis to get to, and it's bigger and floppier. And then you also have the narrowest part, which is at the cricoid. And so it's like a funnel shape, which means that it's a little challenging to intubate sometimes, especially without any history. And then also with burn injury, that also plays a big role here. And that's mainly because it doesn't take much edema for a pediatric airway to swell and become obstructed. So that's why when we have kiddos, we are actually thinking of a smaller TBSA for just automatic intubations. And I'll tell you, there are some controversies around some of the topics that I'm sharing with you, but what I'm giving you is more of like the general gist of what we do in practice, what ABLS helps us to teach and want for all of our providers to understand about the care of burn patients. So here's a really good picture of a kiddo who came in initially, right? Looks pretty good. Looks like they should be okay. They haven't been resuscitated. This kiddo had about a 20% burn. And then here's what the patient looks like 6 hours later. And as you can imagine, it's really challenging to intubate a patient with this much swelling and with such a narrow airway. So it's important to do that. And also, as you can tell, there's not a lot of places where you can stick tape, which is the traditional ways that people have attempted to secure ET tubes acutely. And so we use a lot of umbilical ties and umbilical tapes. So it's important to get the airway secured early, important to make sure that it's secured appropriately too, because if you lose this airway, that could also mean a surgical airway and death for these patients. Okay. So back to our primary survey in progress. Let's talk about breathing. So the traditional things that we do are listen to breath sounds and evaluate the chest wall. If you have a lot of burn across the chest wall, you actually may not hear breath sounds very clearly. You also may not see chest excursion, and you might have to consider some other things. But for every burn patient that comes in, just put them on 100% non-rebreather. You may not know the story, but if they do have some level of inhalation injury, by putting the mask on and giving them 100% oxygen, you are actively treating any kind of systemic inhalation injury with carbon monoxide. So there you go, a freebie. You just need to put the oxygen on. So that can sometimes be forgotten, but it's important to recognize. So some of the key things you'll hear in your history include that the patient was found down in a house fire or in any kind of enclosed space. And you'll want to make sure to check ABGs and carboxyhemoglobins levels to help us determine. If they're on 100% non-rebreather, that will kind of decrease their oxygen, or the half-life will be about 30 minutes to 40 minutes, apologies. But you should have it on there for at least 3 hours. If they're intubated, you kind of don't have to worry about it. When we think about inhalation injury, we do like to break it down based on a couple of anatomical spaces, and then the last space is the systemic space. So we have the upper airway inhalation, lower airway inhalation, and it's based on the epiglottis. And then we have systemic components to the inhalation injury. So let's take a little detour to inhalation injury. I think this is the best way to kind of get all of this information in so that you're thinking about it in the right spaces at the right time as you're thinking about your primary survey. And FYI, just note, we're still in the first 10 minutes of our primary survey, and we're just getting to breathing. So there are a lot of things that we consider, especially as burn surgeons, when we're coming down to the trauma bay thinking about these burn patients as you're going through the primary survey. So inhalation injury, here's a good way to think about it. It's 3 diseases, not one. You have the supraglottic injury, the lower respiratory tract injury, and the systemic poisoning. So smoke inhalation, just remember the products of combustion are carbon dioxide and water. If you have plastics, then you get a lot of carbon. And then if you have incomplete combustion, it can lead to multiple types of byproducts, like carbon monoxide, which is an asphyxiant. You can get some heat, which can induce laryngospasm, and other toxicants, which can cause damage to the lower airway. So those are probably the most common things that you see for the lower airway inhalation injury. You can also develop hypoxia. One, if you're in an enclosed space, there's low oxygen content in the fire in general, but you still may have fire that is going even at 12% FiO2. You can see patients with loss of consciousness, so it's a question that's important when the patient first arrives. That leads to some decreased respiratory drive and hypoxia. And then you have the cellular damage, which leads to hypoxia, and that's when you have like carbon monoxide and cyanide poisoning. So the supraglottic injury, that can be caused by thermal injury to the supraglottic structures. It's almost like a vapor or steam injury to the posterior oropharynx. This results in edema and upper airway obstruction in the initial hours post-injury. Most times the mouth will dissipate the heat relatively well due to the excellent vascularization and the shaping in the back of your throat. It requires more than a short exposure like a flash burn. And it rarely rarely get a thermal injury to the actual glottis or below the glottis. So you won't see like flames in the lower airways. It's really vapor and steam that's causing the injury to the tissues, and you mostly get edema, swelling. Also, please feel free to ask any questions while we're going through this. Okay. For the lower respiratory tract, this is more related to kind of a chemical injury. This develops within the first 2 days post-injury, so you're not going to see the results of it really on day 1. So they might act normally, they might oxygenate well, they might be doing okay, but by the end of the first day into the second day, you start to see evidence of hypoxemia and other things that are indicative of inhalation injury. And so this results in hypoxia primarily because you are actually damaging the alveoli and the cells. And so the products of combustion travel down to the alveoli. This causes an inflammatory response. You can get some bronchospasm in the larger airways. And then at the lower airways and at the alveoli, you get impaired gas exchange. So when these patients arrive, this is what we do up in the burn unit. We do a bronchoscopic grading of their level of inhalation exposure or injury. And here's a grading scale just so you can see. Normal really looks normal. Grade 1 has just a little bit of soot. You start to get more soot and maybe some graying of the mucosa as you move forward, and maybe some erythema. On grade 3, you start to see some inflammation and friability, lots of carbonaceous material and deposits, and lots of bronchuria. And then this is what it looks like for grade 4. You get lots of mucosal sloughing and necrosis of the endoluminal space. And so this is it can become pretty severe. Just know you're not going to see it on a chest x-ray. You're not going to see it on a CT scan. You're not going to see it at admission. It's going to be post-day 1 to 2, but we still have to be aware and treat it early to help with all of the sequelae related to it. So let's talk about the third part of inhalation injury, and that's the systemic poisoning. Carbon monoxide and cyanide. So carbon monoxide poisoning, usually it's a colorless, odorless gas. It outcompetes oxygen to bind to the hemoglobin. It has 200 times more affinity than at room air than oxygen. The half-life at room air is about 4 hours. On 100% oxygen, it's about 1 hour. It also binds to myoglobin and cytochrome, so you have some other impacts to the metabolic system. This can ultimately result in some persistent neurologic sequela and delayed neurologic sequela that we can see weeks after their exposure. So this is one of the important things, and why that 100% non-rebreather is really important. When that patient hits the trauma bay, you start to treat something like this in the first 10 minutes. And it could have really big impact and great impact for their survival and other complications. So moving along, talking about the hyperbaric oxygen therapy for this, we don't have one of those here that is easily accessible. And so we have never had any issues with using or needing hyperbarics just to treat carbon monoxide poisoning. Now, there is one center at the University of Minnesota where they have like 2 rooms. They can dive an ICU room, which has a nurse, a doctor, and the patient. And then they have another room, and it's right off of their ED, where they can dive 10 people with diabetic foot ulcers. So they have a system, and it works for them. But we don't have that available. And the data isn't very clear as to whether or not this needs to or has to be standard of care, because we haven't been able to really find a huge difference or benefit in doing hyperbarics over just 100% oxygen in early treatment. There might be some potential harm, especially if you're diving a big burn and there's complications or codes, because as you can imagine, when you're diving, you don't just jump in and go down to like 100 meters. You kind of take your time going down, which means you also have to take your time coming back up. So there's no way to overcome that, especially if you're having an acute problem. So we prefer not to use hyperbarics. For cyanide poisoning, well, this is often overlooked. We do have some tests. They're sent out, and they take days to determine, which is going to be outside of the window of treatment. So we never actually know if people are actively having a cyanide toxicity. We just think about all of the exposures and the inhalation injury and all of the potentials, and we treat empirically. So it is often overlooked. What happens is the cyanide binds to cytochrome C oxidase. It shuts down the mitochondrial respiration. That decreases ATP production, increases anaerobic metabolism, so you get a lactic acidosis or metabolic acidosis. So this could be sort of like a little trigger when you get that first ABG. Again, blood tests can take over 2 hours and are not widely available. Like I said, I think here it's just a send out, which takes days. So we must be treating these patients empirically. So cyanide treatment prior to 2006 included sodium thiosulfate. Anyone know what that is or ever seen that ever? Speak up, share your knowledge. No? Okay, so this is used to kind of, it's a substrate that just binds up all of the cyanide and pushes it out of your kidneys as thiosulfate and cyanide combined. And so if your kidneys aren't working or you're having acute kidney injury, it can accumulate. But it also has a huge, huge hypotensive response initially when you give it. And so it's really, I've seen it given a few times. When you give it, their blood pressure just drops really dramatically. And you're like, no, 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 let's make it better. Let's make it better. But you can't. You kind of have to ride through the process and go from there. Andrew Rowe, are you wanting to say anything? Maybe not. Okay. And all of the others are kind of similar in a way. So those are kind of the old-fashioned drugs. What we use today, more commonly, is oxycobalamin. Has anyone seen the cyano kit or heard about the cyano kit? So this is what we've used pretty consistently. We do have this down in our pharmacy. It has been on back order and also, just hasn't been available. So we don't always have it, but basically it's just B12 vitamin and it binds up the cyanide, you pee it out, and that's it. But it does turn your urine this really deep, deep red color, which could be mistaken for rhabdomyolysis as well. So here are some of the, there we go. Here are some of the typical symptoms you'll see with cyanide toxicity. Hypotension is common. Also, you'll have the lactic acidosis. Everything else is kind of, you can't really tease it out when you're dealing with a full trauma and you have other issues that are going on. And that's what the cyano kit looks like. And that's what the urine looks like once you give it. Okay. Everyone ready to go back to the primary survey? That's already in progress. Just remember, we've only done 10 minutes. We haven't even completed the first 10 minutes, and we've already had a lot to think about already. So let's talk about circulation. So again, the common things that we always do when the patient comes to the trauma bay, we're going to check a manual BP, we're going to check pulses in all extremities, we're going to assess for hypotension, we're going to take a moment here and stop. If we are having significant hypotension, it is not the burn. It is some trauma thing where the patient bled, and you need to figure out where they bled first before we do anything else with burns. So if you are having ongoing significant hypotension, and this isn't like a 90+% burn, then we need to be really considering some other traumatic injury where you've lost blood in either the chest, the belly, extremities, right? At the floor before they got here. So don't forget any of your trauma stuff. And what I find is everyone gets a little bit, you see these burn wounds and you're like, that's the problem. It looks so bad. But we have to remain very consistent with how we are reviewing and evaluating, and not forget our trauma could be a big part of what's going on here. And then the other question is where do I place my IVs? Anywhere. Just know that at some point with resuscitation, they may become dislodged and they may no longer be in the IV. And so for the short term, peripheral is fine, IOs, don't forget your IOs. Those are really great in burn patients because it's really hard sometimes to find an IV as your secondary access, and then working on a central access in those patients that we are just impossible, it's impossible to get things in. I love IOs for kiddos. They do work very well. So the initial fluid administration. In the first 2 minutes, you don't know really what's happening. You have a patient who has a burn that may be greater than 20%. That's all you know. And if you have someone that you think is at least 20% or greater, then you need to get some fluids started. So you can do your ATLS, 1 liter bolus, your choice of crystalloid. We prefer LR. But you can use normal saline. And you get your fluids going. So we have ABLS really, set this up and said, if you don't really know, but it's at least 20%, just start your fluids here. So if you are an adult over the age of 14, start your fluids at 500 mLs an hour. That's it. And you can just let that ride as you work through the rest of your primary survey and then move on. And then they have numbers for our pediatric patients as well. Okay? We will do a more definitive calculation in our secondary survey, and we'll keep fluids going. Now, the question that gets asked all the time is, well, what if after the 1 liter bolus, they're still hypotensive and we're still in the trauma mode and we're still having trauma resuscitation? Well, then you give blood products like you would for a trauma patient. If there's space to give this, 500 mLs an hour, then give it. If not, then continue down your trauma resuscitation until you get back to this space, and then you start the fluids back up at 500 an hour. Okay? So, Nick Royo. Yes. So if the burn is greater than 20% in the ED, should we go directly to IO? You don't have to, but I don't see a problem in placing an IO as you're finding a peripheral access. Peripheral access is probably, better because you'll get fluid in faster than you do through an IO, just in general. But we will take all of the access, especially if you're having a hard time. Okay? It's not that it's preferred, but there you go. I think we'll take anything. We have actually put IOs up in the burn unit as well as we're waiting for central access. So we just need access. So whichever worked out best for you, we will take it. So core concept around concomitant trauma and the circulation. If shock is present at the time of admission, it is imperative that you search for the other traumatic injury. Okay? If you don't, then you have not done due diligence and you are just looking at the burn injury. Okay? They come later. Trauma trumps burn. So getting over to our primary survey and burn perspective. So let's talk about disability. This is our quick evaluation for alertness, right? AVPU. Do you guys remember AVPU? So is the patient alert? Do they respond to a verbal stimuli? Do they respond to painful stimuli? Is the patient responsive? Or you could do your traditional GCS. This is just a short, quick way to understand their disability. And then just remember, if they are having some depressed neurological impact, you have to still remember there might be a traumatic brain injury. There might still be some ongoing hypoxemia. You might still be in a shock state, so you have to get those things reversed and treated. You also still have to think about carbon monoxide poisoning from inhalation injury and other electrical injuries that could impact the neurologic status. So here is a picture of a patient who had an electrical injury, and this is about 4,000 degrees Celsius. So that's a pretty full thickness injury. Also, exposure. You have to see the entire wound to be able to assess it. So you have to take all the clothing off. Also, the clothing may still be warm and may be, continuing to create burn injury. So we want to get all of the stuff off including jewelry, because resuscitation means lots of swelling. And so if we don't get it off early, then we may not be able to get it off, or we might have to cut it. And so patients, unfortunately, they're not very forgiving when you have to cut wedding rings and wedding bands. So this is something we know was going to happen, so go ahead and remove all that injury. And then we talk about decontamination. Now, it's important to understand that before you even come into the trauma bay, you should have assessed if this patient requires decontamination, right? Because we don't want to expose our team and staff to whatever the contaminant is and make them noxious and sick while we're going through our evaluation. So decontamination technically should precede transfer to the trauma bay or the ICU. Hopefully, before they got on the airplane, they got contaminated, or the helicopter too, because it can have an impact. And the most common frequent reasons that we have decontamination is if we are dealing with patients who had gasoline fires or are doused in a lot of gasoline, patients who have been at chemical plants and there's a known spill or exposure there. We want to make sure that those patients are not bringing in like vapors and also actual chemicals that could impact and hurt us. But in that case, we have to all remember to still wear our PPE while we're going through all of this. And then temperature. Make sure to assess your patient's temperature. This is like the forgotten vital sign, but for our burn patients, it's really important. They don't have their skin anymore. The skin is what keeps your temperature. And so if your skin is no longer intact, you can't do it on your own. So we have to provide it for them. So we have to keep our burn injured patient warm. So let's take a decontamination tour. This is a short tour and just talk a little bit about it. So again, as I mentioned, remember to protect yourself and have your own appropriate PPE on. Any powders you want to brush off, don't wet, because you could activate them. You want to remove all the clothing, and if it was a liquid, make sure you irrigate with copious amounts of water, which is what the decontamination shower does. If you know that there's some other chemical, don't try to neutralize it. You could create a chemical reaction that creates more heat and more injury. We also want to make sure to contact poison control if it's indicated. And I would say, unless you know what it is, we're probably going to call poison control to figure out and make sure that the scene is also contained and they have the appropriate information. And then if we're thinking about chemical injuries for the eye, we want to make sure all contacts are removed, just like any other trauma as well. We do test some pH with the litmus paper to assess that we're in normal pH. And then we may have to do, some forced irrigation because there's edema, and that's a little challenging. So that's why we call our ophthalmology colleagues to help us with that. Okay. And just for you guys, if you don't remember, here's your UUHC decontamination workflow. It is on Pulse, but I put it here for you so that you can see that there is an actual workflow, and there are personnel that need to be notified and involved and in charge while this is happening so that we create safety for the patient, safety for each other, and then get the patient to the right place immediately. Okay? So I'm not going to read that. You guys can read. Okay, back to our primary survey, still in progress. Oh man, I'm just kind of tired after that. So we just made it to, just thinking about the core concept of exposure environment. Again, make sure to expose the patient so that you can evaluate all the injuries, but then cover them up really quickly to make sure that they don't get cold. Cold patients are hypothermic. Then they become coagulopathic, then they become acidotic. And once our burn patients are in that space, it's actually really hard to rescue them, extremely hard to rescue them because it's hard to get their temperatures back. And then this also confused like things like cyanide poisoning. Is this lactic acidosis because they're cold or because they have a cyanide poisoning? So it's important to make sure that you meet all of these things as you're going through your primary survey for a burn injured patient. Okay, so just remember how hot it is, how thick the liquid or substance is really impacts the depth of your injury and the extent. So that's one thing. Okay, we made it through the first 10 minutes. We've just done a primary survey. That's it. So if you have any questions, please make sure that you you say something. Oh, we have a question. Can you share with the ED the best warming options? Okay, thank you, Ashley, for priming me for that one. So a lot of times the bear hugger is in the ED. But I'll tell you, if you have a wet wound and you apply a blowing heat, you just create an air conditioner with hot air. That's it. So you actually will be cooling the patient. So what we recommend is if you want to still use that, we would have you have a blanket, plastic, bear hugger, blanket as a kind of sandwich of things so that you don't have direct air flowing over the patient and you truly get temperature rising. Okay. Any other questions on that? So we've made it through the first hour, and now we are to the second hour. And now this is where we start getting into fluid resuscitation, and I can stop talking about all the trauma stuff now because that should be taken care of. If they needed surgery, they would have gone off to surgery, right? We're now in our part, okay? So now let's talk about the goals of resuscitations and why do we do that? Because if we don't understand why we're doing what we're doing, we'll keep doing stuff, but we won't ever get anywhere, or we'll do it inconsistently. So our resuscitation, we have to have proper fluid management, and it's critical to the survival of our injured patient. That's just it. We just have to have the fluid. They lose all of this fluid when they get burned, injured, and we have to spend 24 hours trying to give it back in the best, optimal, most nuanced way for the following 24 hours. And so resuscitation is aimed at maintaining tissue perfusion and organ perfusion and function. And then we also want to avoid any complications of inadequate or excessive fluid resuscitation. So it's like Goldilocks. We have to live in this perfect world where we give the perfect amount of fluids to get, perfect function for our tissue and our organs, but not give too much or too little, just right for Goldilocks, okay? So that's a good way to kind of remember our goals for resuscitation. So I forgot, with our secondary survey, we do have to go through from head to toe and do a full exam. We also are continually assessing our ABCs and neural status. And then we also want to determine the burn depth. We'll get to that in a minute. Remember your sample history where you can get some important data. Make sure you get this before you put the breathing tube down. Sometimes our patients, they don't have friends or family. And so it's really hard. So if you could just get a little bit of data for us from that sample history, that will help us go a long way in the care of the patient. And then place a Foley, a gastric tube if they're intubated. Of course, always reassessing if your IV access is working or stable or hasn't been dislodged is important. And now let's calculate and start a burn resuscitation for the fluids. And then we'll talk a little bit more about this antibiotics, the prophylactic antibiotics that everyone likes to give for burn patients. So TBSA, this is the total body surface area assessment. It gives us a percentage of burn size based on the body, basically. And the reason we can do that is because our body surface area is about the same size as our mass. So we can make some guesstimations about that ratio. Now, for pediatric patients, that is not true. they have more surface area and skin than they do mass. So they become a little bit more challenged, and they can have bigger burns for the size of their bodies. And so everyone remembers the rule of nines, but let's talk about it again. This is where we can assess the size pretty quickly. If you remember the nines, each arm is 9. Legs are 9 on the front and back. The chest is 9, the belly is 9. So you got 18 for the torso, front and back. And then the head is 9%. So that makes it really easy. And then the genitals are 1%. There you go. When you think about kiddos, though, this is a little bit more challenging. Their heads are bigger, their torsos are bigger, their limb extremities are smaller. What I like to use is the palm rule. This is your 1%. Your hand is your 1%. So you just put it on their face or the body. 1, 2, 3, 4, 5. You know, you can count like that. If you really kind of lose it and you're like, I don't know how to add 9 plus 9. It happens in trauma situations with stress. So you know this is their 1%. That's a really easy thing to remember. And you just like mark it out on them and help you to understand. It's difficult to be really accurate in the primary or the secondary survey. Really, you're just getting a guesstimation. You're going to clean up all these blisters, and we're going to get a better assessment. A little bit to the basics of skin anatomy. Just remember, we have an epidermis first, then we have the dermis, which is the biggest, and then we have fat and underlying structures like muscle, fascia, bone, tendon. The epidermis is really small, so that's what the blister is occurring at the layer between the epidermis and the dermis. Because the dermis is usually the thickest part of the skin, you can have different types of dermal burns. So after the epidermis, we have what we call partial thickness injuries, and they can be superficial or deep, and it's because the dermal layer is pretty thick. Okay? But it's still small. It's on the order of like 1/10,000th to 20,000th of an inch thickness. So it's still fairly small. That picture, that depiction is not real life. One thing to remember is first degree burns, they don't count. This is just damage at the epidermis. You have no blisters. The skin is completely intact. This is when you went to Cancun and you went out, you know, swimming with the rays and you forgot to put on your suntan lotion, and later on it pills that you had a first degree burn. There you are. But because the skin is intact and you're not losing fluid, it is not counted in our calculation for burn resuscitation. So if you're not leaking fluid, there's no need to resuscitate. Though there are these caveats where people have full body sunburns who do get dehydrated. So that's the caveat. And so they can have some severe dehydration, especially in infants and elderly. We usually just rehydrate and treat with some over-the-counter analgesics to move forward from there. So here we have the second degree burns. Now we're below the epidermis and we're into the dermis, but we're on the top half of it. And so these are more pink and moist, and they're very painful. There would definitely be a blister that is along with it. These will generally heal spontaneously with just good wound care and moving along with life. This is more painful because the nerves are exposed. As you get deeper and more burn, that means that you're killing off more tissue and more nerves, and so it's less painful. So you can have severe fluid loss with that. When we get to the deep partial thickness burn, they may be moist, but they have more of a pale white appearance, and they are moist at the same time. Under the blister, these may heal spontaneously, but they may also need skin grafting to some degree. There is a high potential for scar formation when you start to get into deeper layers of the dermis and into third degree areas. So third degree, this damage is through the epidermis and the dermal layers into the subcutaneous fat. These wounds, especially if they're bigger than a silver dollar, will require skin grafting. So you can see some examples here along the right side of the screen. They're generally not very painful. They appear dry. So that's the difference between second degree, third degree. They're very dry. They can be cherry red like that other picture, but they'll be dry as an indication for full thickness, or they may be gray and leathery and sort of this off-white color. They can also contract a lot as well, and that will require excision in order to be helpful. And it can also lead to compartment syndrome, so we'll have to talk about that a little bit later. Fourth degree, fifth degree, you guys don't see that very much, but in an electrical injury, you will see that. Or in patients who've had such prolonged exposure and being on fire or exposed to the heat source will have these injuries. And so these are really complex surgical management wounds and injuries. This is most common, like I said, in electrical injuries, and they often require amputation. And so they're really sad stories. They can also be pretty good stories when you see people who survive them. Okay. So I might need a little audience participation. So if you can in your chat here, I'm going to point to this picture. Can someone tell me, just put a 1, 2, or 3, is this a first degree, second degree, or third degree injury? I see 1. I hear Cancun. 1. Great. Awesome. 1. Yes. Fantastic. So I'm going to be very specific now with my little cursor. Is this a first degree or a second degree in this area that I'm circling? 2. Great. Awesome. Fantastic. Great. Now, what do we think about this picture over here? What do we think's going on with these little leggies? What degree? First degree. Got a lot of 1s. I'm going to add to the story that she went on to lose all of her skin. But it started off as a sunburn. It was just a really bad one. Thank you, Sydney, for the 1.5. And just so you know, what you see at admission is not actually the truth of the wound. And burn surgeons are about 60% accurate, 60 to 70% accurate at assessing burn depth at admission. We get smarter and better with time. So after about 3 to 5 days, we know the truth of what's happening to the wound. But at admission, it's a little challenging. Okay. Let's take a look at this one. Can you guys give me a 1, 2, or 3? What depth do you think this wound is? 3. Great. Fantastic. So you can see the skin is completely pulling away. It's gray. This is one of the traditional flame burns. The skin is white, dry, leathery. So some people actually might assume that this is actually normal skin when it actually is not. So that's why I'm looking at this picture specifically, okay? Because some may say, oh, that looks like his normal skin, and this is the peeling skin, right? But this is actually a third-degree injury. And if you're having trouble, just remember, look back to normal tissue. He hopefully has some other normal tissue somewhere else on their body to help confirm your exam, okay? Let's see. What do we think about this injury here? Have a 2, some 3s, a deep 2. This looks more like a 3, and I'll tell you why. 1, it's more coagulated and congealed, so you can see these spots coming through. You also have a little bit of a waist, which you can't appreciate on this photos, but it's like kind of contracting down a little bit too. So you usually see that with third degree and less often with like second degree injuries. Okay, so here's the question I get, we get a lot. So what about the wounds? Well, we need wound debridement in order to have accurate assessment of the size and depth of injury. So if we don't do that, we have, it's like walking in the, dark trying to figure out how to make people better. We just need to remove all the blisters for us to be able to assess and calculate the fluid resuscitation. So wound debridement is necessary for the size and depth. Also, this dead skin is a source of infection, so it's also another reason for us to remove it. Wound management tour. Here we go. Hope you guys are ready. For my burn nurses out there, just forgive me. This is more of a short overview versus being inclusive. For everyone else, I think you'll enjoy it. So there is the importance of proper burn wound care, especially early in their treatment, is important. Invasive infection is responsible for about 42 to 65% of the deaths we see in burn-injured patients. Burn patients with infections are more likely to die, 2 times more likely to die, compared to their counterparts who do not have infection with a burn injury. When we think about skin and soft tissue infection for burn patients, it usually occurs within the first week of hospitalization. So we know we're going to see infection in our burn patients. We just don't want to select out for bad things. So it's always important to have adequate wound care. And that has been shown to consistently decrease incidence of infection. And actually, Dr. Dakins, back in World War II time, and was it World War II or I? I'll have to get back on. I. Thank you, Drew. He basically showed that when he put bleach on the wound, people lived and they saved their extremities. And it was by a significant amount, from 30% survival up to 80% survival. And he just did wound care. That's it. So it's really important, and it's important to our burn patients. And so we always like to think about the perfect dressing, right? What would be the perfect dressing? Well, it would have some antibiotic coverage. It would make it heal faster. It would control the moisture. It will allow for mobility. It will be easy to apply. It would be, decreased pain. And it would be at the low cost of nothing. It would be free. And then, we look for that, but it doesn't exist yet. We're still working on that. We're still behind at times, but that's where we are. So we do have some burn wound topicals and dressings that we use pretty commonly. So we'll have some of the medications we'll talk about and some of the dressings we'll talk about. Okay. SSD, you guys have heard us. Everyone thinks it's the devil, but it's really good for really deep, partial, and full thickness burn injuries. It helps to clean the wound. It has silver that binds and blocks DNA synthesis in the bacteria. And that allows for the antibacterial component to it. And it basically is also very soothing because it has this cream that's cool, and everyone is like, oh, please put the Silvadene on. That makes it feel better. Some of the side effects that you'll see are neutropenia, but I'll have to say and caveat, we don't know if that's because of the Silvadene or if that's because of the burn, because you will see neutropenia or pancytopenia in big burns, especially early on in their care. Patients who have a sulfa allergy, they may have an allergic reaction. I've not ever seen one, but we always test because it is a sulfadiazine or sulfa moiety is involved in there. And then if it's close to the eyes, it could cause some eye damage. And we definitely don't want to use this in patients who are pregnant and approaching term. or premature infants or newborn infants during the first 2 months of life, okay? So those are the patients that you never use it on. You never put it on the face either. So just remember that. No faces, no babies, and no like approaching term mommies. Sulfamyelin can come as a cream or a solution. We like to use it a lot on our grafts. It has pretty broad coverage. We are not sure how it really works, but it's more of a bacteriostatic versus cytal. So it works against gram-positive and clostridial things, and it can penetrate through full-thickness grafts or full-thickness eschars or full-thickness burns. So that's part of the reason we like it. Just remember, it is carbonic anhydrase, and it may cause a hyperchloremic metabolic acidosis. But you usually get compensation if you're on the ventilator because you're hyperventilating, or the patient might have a tachycardia to kind of compensate, and that might be an indication. If you have hemolytic anemia, or it can cause hemolytic anemia in patients with G6PD deficiency, we are not in a children's hospital, so hopefully we don't see that very often. And it may be associated with more pain. It's an acid base, so it can cause some more pain when applied topically. Bacitracin, polymyxin, these are ointments that you guys are probably pretty familiar with, polysporin. These have pretty broad coverage as well, and they are mostly bactericidal. There's very few precautions or side effects. And that's mostly because there's low systemic absorption of these things. Now, if you have higher, then we might get into some problems. But you have a pretty good broad coverage, including Pseudomonas and Acinetobacter. Bactroban, you guys should all be familiar with mupirocin or Bactroban, neomycin. These are really, really good at getting to Pseudomonas and our bactericidal. Specifically, they have an impact for MRSA infections, specifically for Bactroban. And again, they have low systemic absorption. And Neosporin, just so you know, is a combination of both neomycin, polymyxin, bacitracin. Adaptic is, just think of it as greasy kind of gauze with a wide mesh. It's non-adherent. We always want to use our ointments or medications with a layer of a non-stick or non-adherent dressing type before we put gauze on. Otherwise, it will stick to the wound, and that will be very painful later on. Zeroform is another greasy gauze. It has bismuth tribromophenate and basically grease, and that's on fine mesh gauze. It is occlusive at times. It can be non-adhering, but if you're not careful and leave it on too long, it could adhere. And it conforms well to the wound as well, so that's one nice thing about it. Acticoat is a silver product. We used to use it a lot. It basically has silver that it sprays onto the wound when you activate it with water, but it feels like wearing wet aluminum. So it's not a dressing that we use very often, but it's there, and it's bacteriostatic to Pseudomonas and MRSA. You'll see us use this very rarely for big burns, but we'll use it in some other special occasions. Mepilex AG, we will use this for second-degree wounds. This is a nice, soft, kind of sticky pad. So it's comfortable. We'll put this on a wound. It's supposed to stay for 7 to 14 days, and then it heals as you peel. And so that's one of the nice things about it. Superthel, this is something we just specifically use in our burn unit because it's a pretty expensive dressing. I doubt many people will have this down in the trauma bay just using for wound care. So it, again, is a polylactic copolymer, basically gets absorbed into the wound interface and creates like a scab, and over time it peels away. So that's why we kind of like it. And here's just a general overview of our common burn wound infection types. on the left side of your screen, and then on the right side you have the common topical treatments that are associated with that, or that we use more commonly for treating these types of infection. And there's a lot of overlap because these are broad spectrum topicals. So that's the important part about it, is that we get to hit a lot of different types of bugs that could live on the skin, and have some antifungal or antibacterial, antifungal protection. So to this question, to give or not to give prophylactics for a burn injury, we strongly recommend not administering prophylactic antibiotics, okay? And here's why. We've talked about it around robin, so I'm just going to directly answer it now. So in the acute phase, day 0 to 7 of the burn injury, which is the first week, you can already start to see staphylococcus infections and other skin infections. As you move past the first week, we start seeing all of these weird, unfun bugs and other infections. You start getting more urinary tract infections, bloodstream infections, pneumonias. You also start to develop antimicrobial resistance. So between that first and second week, your antimicrobial resistance is just building. You also start to have emergence of fungal infections after, the first 2 weeks as well. So it's very important to be a steward at admission for these burn patients. Yes, they will have some infection. You will not prevent it by giving your prophylactic antibiotic. What you will do is you will select out for antibacterial resistance and make it more challenging for us to later be able to treat effectively any bacterial infections that they may develop. And they are destined to develop it, okay? So this is just a stewardship and helpfulness around antibiotic treatment in our burn patients. Now, if you have a trauma and you have an open fracture, you should treat with your antibiotics, okay? But if you're just giving prophylactic antibiotics for the burn wound, that is not recommended. Okay, back to our secondary survey. Maybe we can get our resuscitation calculated before we finish here. So we have the ABLS consensus formula, and I borrowed this from the ABLS manual. And this is currently the recommendations for how we calculate fluids based on the burn size or the burn patient. So again, this is really here for us. If you really can't remember, always remember 4 times the weight in kilograms times the burn size, whole number percent, not 0.5 for 50%, but 50%, okay? The whole 50 number. And here's how we calculate it. It's really pretty straightforward. And what we're trying to get at is the start rate. Where do we start our fluids for resuscitation? So if we have a 10% burn in a 70 kilogram person, we're going to calculate the 2800. We'll divide that by 2 because we're going to give half of it over the first 8 hours, and then we divide it by 8 to get the initial fluid rate, which is 175. If we have a bigger burn, look what we get. 1,250 mLs an hour. That's a bolus. But that is their fluid rate. And now you want to titrate. That is a lot of fluid. So just recognize that our fluid rates may also be your bolus rates, and it can sometimes be a little bit of a mind shift to think about it from that perspective. But it also gives you some idea of how much fluid you're actually giving this patient. So this patient in 24 hours is going to get 20 liters of fluid. That's a ton of fluid. That's what they're estimated to get. And you can imagine there's going to be problems with that. You can also imagine that if you don't give the right kind of fluid, that you can have all sorts of electrolyte problems if you're giving 20 liters of fluid. So for us, when we look at what our own physiology looks like in the extracellular fluid, lactated ringers are really a little bit closer to what we would see, and so we don't get too much of a variation in our electrolytes, but we do have this problem with sodium problems. They become a little low, especially when you're talking about 20 liters. However, let's say we did decide to use normal saline. Well, what would be the problem? Well, we'd get a metabolic acidosis with hyperchloremia. And that could be really a challenge for these burn patients, from one, being able to understand what's happening with their physiology because you have this acidosis that you can't correct. And it could also contribute just to the overall acidotic system, especially when you think about bigger burns. So it could just contribute to the overall sickness of the patient. So how do we know if we're giving the right amount of resuscitation fluid? Well, it's your urine output. That's really the best thing we have right now. They've tried all sorts of other things and tools and fancy gadgets, and we keep coming back to urine output. This is kind of the best way to assess. So for adults, we're really just looking for adequate. We're not looking for perfect. We're not looking for super normal. We're looking for adequate urine output. So 30 mLs is still the recommended amount of fluid per hour for adults. For kiddos, we're still looking at about 1 ml per kg per hour for them. And you could waffle about that a little bit. And then if we have electrical burns, especially if they're having rhabdomyolysis, so their creatine kinases are pretty high, and we have other indicators for rhabdo, then we will be aiming for actually higher numbers of urine output in the 50 to 100 mLs per hour, and that's so that we can just flush out all the proteins from the breakdown of the muscle. So let's talk about burn resuscitation on one slide. And here we go, burn pathophysiology. So this is why we give fluids continuously versus bolusing. So when you think about the burn wound, what we get is the burn injury, the systemic inflammatory surge and storm that creates leaky vessels, and then all of your fluid goes out into the interstitium and it fills up the 2/3 extracellular space and then the 1/3 intravascular space. So if you're not careful, all your fluid's going to go out into the interstitium and you won't get anything in the vessels, and that's a problem. And so we want to get to euvolemia. This is our goal. And we're looking at extravascular fluid leak. So this is your extracellular space. And this is what a bolus looks like. And this is what it looks like when we're just giving an infusion. So next slide. So here's what we equate that to, a colander, right? So if you give fluid slowly and continuously, they're more likely to stay inside those leaky vessels versus being pushed out into the extracellular space. And so this is the equivalent, the pictorial equivalent of that. It's just leaking. Versus if you give a bolus, what will happen is all your fluid would go in and it'll flush out. I want everyone to go home and practice this and see what the difference is when you turn on the tap really slow versus turn it on really high with your colander. And you'll see you do get more fluid in when you just do a continuous drip, okay? So that's burn resuscitation in one slide. Okay, so just a reminder, our resuscitation goals are to maintain end organ perfusion. Skin is an organ, remember that. Okay, our endpoints are urine output, as we discussed. We also use other things like serum lactate. We trend other vitals and things like that. Our goals are to do this optimally. So we want to titrate our fluids right after we get our initial amount. We start titrating every single hour. And if your output is adequate, then you can decrease your fluids. If your output is inadequate, then you might have to increase your fluids. And so that 20-liter resuscitation starts to look a little bit like 30 liters or more. It's hard to say. If we're getting into the levels of 20-liter resuscitation, we know for sure we're going to start to have some bad outcomes because we have too much fluid. And so we'll start adding things like albumin to help reduce the total volume of fluid that we have to give one patient, because there are problems with giving that much fluid on a for a 24-hour period, as you can imagine. And guess what? We'll talk about them. So here's the UUHC burn diagram that we use. It's the Lund-Browder. It's a nice sort of diagram that breaks it down based on age and then based on the joints. And it gives us a little bit more specificity when we make our determination of the size of the burn. And then it has all this important data to help us navigate calculating initial fluid rates. Once we move forward, then we have our burn resuscitation protocol, which is nurse, MD driven together. It was initially just nurse driven, and I think we've outgrown it, and we're moving more towards revamping to, a little bit different kind of resuscitation. But for now, this tells you like if your urine output is low, normal, high, normal, and it also tells you how to start the albumin protocol. So if the patient's still down in the trauma bay, and we are, a few hours into this and we're going up on fluids, you might see us say, let's go ahead and add albumin now, and then the calculations become fun. Just reach out to one of your burn nurses, they'll help you. So that makes this, do steroids have any role in management as in sepsis? They have no role here. Steroids will, if the patient has shock state that's refractory and we're on pressors, we've done the adjuncts with albumin and they're still refractory and hypotensive, then we consider adrenal insufficiency and then we'll start steroids or give like a stress dose. But we do not do any empiric, we try very hard not to do any empiric steroid dosing for our patients because it is very counterproductive to wound healing, and it also increases the risk for infection later on. So when we think about who requires more fluid during burn resuscitation in general, again, patients who have burn plus trauma, electrical injury we've talked about, patients with inhalation injury, it's like adding another 13% TBSA to the entire injury itself, and so they will suck up more fluids. If we have a delay in resuscitation, so people coming from Montana who didn't get resuscitated appropriately, then they will also have an issue and require more fluids in a delayed state. If they were dehydrated, if they are on drugs or were taking alcohol, meth has been the soup du jour recently. Those things really, people who are abusing those or actively using or using on the day of, those really kind of have a huge impact on the amount of fluids that they required in their survival as well. And then just your good old third-degree burn injury or deep second degree, those patients will require more fluid in general. So let's talk about some typical resuscitation curves. So let's see. We all want this to happen. The patient comes in, we start our fluids, we do our every hour titration, and every hour we are reducing the fluids every single hour until we get to 24 hours, our maintenance fluids, and we're good, we're done, we're out, we did our job, we're perfect. However, that doesn't happen. We may have someone who comes in, and this curve is probably more traditional for our bigger burns. We start the rate, nothing happens. We're still here, nothing happens. Then we get this like little moment where the fluid goes down and we're like, oh good, we're going in a good place. Then it goes back up and then it comes back down. So these are probably the more challenging resuscitation, but everyone has their way that they can go through. Here's another one. They look like they're going to do perfectly, but then they end up requiring more fluids and then they ultimately have a transition. Everyone can still see everything? I'm just getting some signs. Okay, great. So just recognize that not everyone is going to march through their resuscitation, one, the same way, and two, in a linear fashion. Because that's what we think is going to happen, but that never happens. Unless you have a more superficial burn. So the other thing we noted, and the reason why we have a nurse-driven resuscitation protocol, is that, over time, people tend to give more fluids because they were like, well, if you have a little bit of urine, isn't more urine better? And if we have more urine better for longer, isn't that better? But then we start having problems with excessive fluid resuscitation. So right now, we average about 5 to 7 mLs per kg per percent. When we look at multiple centers across the nation, that's how much fluid most patients are getting when we're resuscitating. And that's still pretty high because it was first at least thought that maybe somewhere between mid 3s to low 4s was kind of the average percent or the average resuscitation requirements per kilogram. So some of the things that they thought about in this fluid creep is that some of it's the nature, what the doctors are feeling. It's also kind of, that's that clinician's behavior. Also, sedation and analgesia have been really indicative of the amount of fluids that are required because they do cause vasodilation, and so that can lead to hypotension and a requirement for more fluids. So just be aware of this. It's something we think about on a regular basis. And that's why we use colloids. Albumin is our choice. FFP is another common use, but we have blood bank shortages, so I think using FFP can be a little bit irresponsible in that space. There's lots of studies that support use, but there's nothing that says that you have to use albumin, you have to use FFP. Pentastarch is not really used and shown to be detrimental. So just know that that was one thing that was tested. But most burn centers will use some level of colloid in the first 24 hours to reduce the total amount of fluids being used. And some of them will also wait until hours 8 to 12, which I think is a little late, to avoid this potential capillary leak of the colloid, which could worsen. They think it may worsen the swelling and edema peripherally. So let's talk about some of the complications of resuscitation. Over-resuscitation is bad. It results in edema and other complications. Those include orbital compartment syndrome. Okay, that's when your eyeball, the tissues around your eyeball get swollen and it presses in, and the pressure is so high that you could actually develop cortical blindness. So we have to do a release of the canthus to be able to release the pressure and allow normal flow through the vitreous and the optic nerve. Abdominal compartment syndrome, I think people are most commonly aware of. Extremity compartment syndrome, I think everyone is also aware of. The other parts of the over-resuscitation that you may not think about is ARDS. So we do get inflammatory ARDS after burn injury with or without inhalation. So you don't have to have an inhalation injury to get ARDS in our burn population. You can also get massive pleural effusion. So if you're not thinking about it, that could be a potential problem. And then cerebral edema. So you might see some neuropathophysiology in your patients, especially as they start to have fluid resuscitations that are bordering on 1 liter or more per hour. So a thing about compartment syndrome and releasing the pressures. Again, this is you reassessing pulses throughout your evaluation, and we're still in the secondary survey. Don't forget, we're still finishing that part up. So if you have burns that are full thickness, that are circumferential, and you have a massive resuscitation, you have a high risk of requiring escharotomy because you'll develop compartment syndrome. What is that magical pressure that is an indication that you have high compartment pressures? Anyone remember the number that you need to release? Put it in the chat for me. 20? Anyone else? No one else wants to guess? Okay. Okay. Anywhere else? Okay, so you start getting into the compartment hypertension, certainly around that 15 to 20 mark. 25 is definitely an indication. We try to be a little bit more elegant about it, and we'll transduce a pressure And if anything's over 25, we'll do a release up in the burn unit. Just remember, escharotomies are not emergent, they are urgent, but you have 6 to 8 hours. We're just still in the primary, the secondary survey, and everyone is really like, oh no, we have to get the compartments taken care of. No, we have to get the resuscitation started. We have to get the patient stabilized. Escharotomies come after all of that, okay? The only one, the caveat is if we have chest compartment syndrome. Now that is not going to look the same way as a extremity compartment syndrome. You will see features like a circumferential torso burn or maybe a full anterior torso burn. That's 3rd degree. Because we don't breathe out of our back. We breathe front in our chest and our belly. So if you have a full thickness injury there, you have a high risk for chest compartment. What you will see is on your ventilator is high pressures, small volumes. Your peak airway pressures will probably be off the chart as well. And so these are patients who probably deserve an emergent chest decompression or chest escharotomies to release the pressure. And that, again, your burn surgeon should be involved in having discussions around that. And then this other thing, which is small but big but small, is pain management. Sometimes we have a hard time remembering pain in our patients when they arrive, just in general. Just remember, burns, especially superficial burns, they hurt. They hurt a lot. So if you're concerned about pressures or the impact it might have on pressures, we just suggest small amounts of short-acting analgesics, usually IV. We tend to use fentanyl as our first line. And then we have frequent reassessment to see how they responded and if they need more. And then educating patients about why they hurt, a reminder of that. And then remember that the patient will not be pain-free. So even after narcotic administration. And so it's really important to think about it from that perspective. And here we have just the referral criteria for consultation of the burn to a burn center. And I just put this in there just so you guys know what we are, being responsible to in our community as well as here in our own system. So pretty much anyone with a burn over 10% is coming, at least getting a consultation from us. Burns over any joint, face, special areas like perineum, genital, hands or feet, we're going to get a consult on. 3rd degree injury, any size, extremes of ages, any pre-existing medical conditions. So you can see how this list means that if you have a burn, just call Burn Center. We can help you out. But, there are some things that we think can be cared for out in the community. So just remember, we just finished the first hour of our resuscitation. Everybody feeling good about that? Excited, happy? And again, there were a lot of details in that space that we have to go through and think about as we're doing our primary survey, secondary survey. So now let's talk a little bit. We're getting out of the trauma bay, and we should be transferring in the first hour up to the burn unit unless there's other concomitant trauma that we have to deal with. And so, again, that's where we start talking about transfer to the ICU. We want to make sure to continue our resuscitation, monitor the urine outputs. We're still in our resuscitation trend for the first 24 hours. We should be getting some laboratory values back and correcting our abnormalities. We will be losing all sorts of proteins and electrolytes through our skin when we're burned. So we have to make sure that we're replacing those aggressively. And then we're also using them in the shock state, in the inflammatory state. This is also the time to reassess a need for escharotomies if you haven't done any. And if you're noting that pulses are changing with resuscitation, and you're doing your wound management as well. And then we start talking about nutritional requirements. Just side note, most of our burn patients, they sit at the top of the sort of resource use when it comes to physiology and injury. So Burn patients require somewhere between 35 to 45 kcals per kilogram, followed by trauma and sepsis, which is somewhere around 20. And then normally we're somewhere around 15 to 18 per kilogram. So our patients need nutrition. If we don't get it in early and start early, then we end up having wound problems and infection. Okay? And here's just a little fun picture about abdominal compartment syndrome. If we don't treat it, we get dead gut. That's not good, and that is not compatible with life. If you have a burn patient, that is almost fatal. Not almost, it is fatal. So if you have gut ischemia and you have a big burn, that's pretty much palliation and comfort care. We like to use bladder pressures to assess. So once the patient's coming up to the ICU, we're going to start assessing the bladder pressures pretty much every hour to every few hours so that we can understand how they're progressing with their resuscitation, especially big burns. And then we get to, we've made it through our resuscitation. Here are the questions. Was it successful? That's really important to be successful. Successful means we've made it down to their weight-based calculated maintenance fluid rate. So it's like what you would need, just a baseline based on how much you weigh. And if they've done that, then we call that success. Is it still ongoing and refractory? Well, we've probably already added the colloids. If we're at the 24-hour mark, I'm just going to say this patient is really sick. They're not actually doing really well from a resuscitation burn standpoint, and their physiology really is not responding well, and they're having a huge response. And so it doesn't bode well when your resuscitation is refractory. It sort of is an indicator that things may be going wrong. And here we are, George. If we have made it through and we're still refractory, we've made it to vasoactive medications, we may add a steroid if we still think that they're hypotensive but they're euvolemic. Again, we're still assessing for compartment syndrome. What you will see us do is we will prophylactically or empirically do escharotomies in areas that we know for sure are going to get worse with time and large resuscitation. So we don't oftentimes have to do more escharotomy, which is just opening of the skin, but we may develop a compartment syndrome, so we might have to transform our escharotomy into fasciotomies. So if we're still having ongoing issues. And then we start getting into the pulmonary edema and inhalation-related ARDS. And then we will also continue with nutritional support, ongoing daily wound management, and pain control. Are you guys tired of listening to me?
Never.
We're at 48 to 72 hours now. Okay, so we're 2 days in. We're still just doing a lot of the same things. Now, for our group, we know, and there's data to show, that when you take off full thickness burns early on in their course, and that's like an immediate or early excision, you can actually reduce the inflammatory insult from that burn injury. So you might see us taking the patient to the operating room and excising their burn injury to help them overcome, especially if they're in refractory resuscitation, help them overcome that physiologic state and get them back to normal. And that's really important. So you'll see us doing that in the first 48 to 72 hours to help further optimize their potential for surviving. So we'll have ongoing monitoring of their input, output. We're done with resuscitation, so we can let that go. Now we start getting into the other critical care needs. We also start optimizing more nutrition and therapy, actually, at this time as well, and pain management. We typically will transition everyone to as much oral medication as we can safely to get a good result. Thanks, Ashley. And then we start thinking about discharge at the time of admission. So a lot of our patients, as I mentioned before, they don't have friends or family. And so if we don't start that process early, we could be in a hurt locker when we actually get to the time of discharge if we haven't started basically really assessing what the resources are that are available to those patients. And again, in this ICU setting, we are also monitoring and treating any care-related infections like ventilator-associated infections, UTIs, wound infections, sepsis. We're preventing infections with washing our patients, making them shower, doing wound care. Those are all really important. And then we're initiating our physical occupational therapy. And as I mentioned, we're already thinking about surgical interventions to help get the wound closed and healed, which is ultimately how we get the best outcome and survival, and then getting them home to patients and families. There's usually a huge psychological impact from a burn injury. We get a lot of acute stress as well as PTSD and depression that can come along with it. So we start early intervention in the hospital while they're actively receiving other treatments. So that brings us to this moment where we get to summarize our tour of burn injury management. And so I just want to make sure that you understand in the initial and early care and management of burn patients, some of your priorities. Remember the airway, secure it early, because you may lose the chance and you would be in a place where you have an obstructed airway. Decontamination, remember, keep your treatment team safe and also keep the patient safe and get them through. Access is also important. Remember, you can use a peripheral IV, IOs, central lines. You just need to get access because we have to resuscitate the patient. Burn resuscitation, we're going to titrate that, right? No longer are we do the set it and forget it. You give half in the first 8 hours and then you give the same rate over the next 16 hours. We're titrating to optimize the Goldilocks fluid to get end organ perfusion. Don't forget to assess and treat your patient for inhalation injury in the first 10 minutes when they're arriving to the hospital in the trauma bay. And then remember to keep them warm. That is 36.5 degrees or warmer, okay? Not 36. Not 36.1, not 36.2. 36.5. This is a real big important thing because I've seen patients who are seeming to swirl downstairs, and we get them upstairs, we warm them up, and their physiology goes back to normal just by heating them up. So just remember, keep them warm. Frequent compartment syndrome assessment is also important early on in their management. And then don't forget to give them some pain medicine, especially while they're downstairs in the trauma bay. And then we do early nutritional assessment and early enteral feeds. And then get them to a burn center fast. And just remember, you already have one here at UUHC. And then, again, I won't belabor this, but remember to secure the tube. It's imperative. Fluid pearls. The time of burn injuries is the time start of your 24 hours. So if it happened 3 hours ago, it doesn't matter. This is where you start. That's the time you have. It's 24 hours from the time of injury. And then please try not to bolus our patients with burn injuries unless you're under ATLS and you're treating for trauma. And then urine output is certainly the best monitor for now. And then the temperature, I won't belabor it too much more. So we do have resources for education, just in general, for burns specifically. Myself and Annette have worked pretty closely with the state of Utah to develop the Utah Burn Crisis Standards of Care. There's an actual app, there's videos, there's other educational resources, and understanding kind of what we're doing in the Intermountain West around educating for burn injuries and how to access things, especially in disasters. So just remember that this resource is available. There is an app that you can get access to. And it has some really nice like flow diagrams and algorithms, especially if you're down in the ED and you're like, oh, I don't know, I can't remember. This will give you something to some framework so you can move forward. I do think we have some charts down in the ED. If not, I'll make sure that Annette updates that so you guys have like a big sort of thing that you can put on the wall to remind you about burn injury. And with that, I'll remind you and say thank you to our wildland firefighters, and thank you guys for listening to me, and I'll take any questions.
And you guys can unmute if you would like to talk, or we will look at the chat as well.
Okay. So Ashley, so what are some of the common issues you notice when receiving patients from the ED? I'll tell you the biggest one that's hard, the hardest for us to get over is actually the hypothermia. We see a lot of patients coming up like 33 degrees, and that really delays our ability to accurately assess them, because we know how important it is to warm the patient. So we may not get an accurate assessment, so we are working in the blind trying to get the patients resuscitated, but not being able to accurately calculate their fluid resuscitation needs. Thanks for that question. Lily? So the Carol, the bear hugger doesn't stick. What it does is it causes an air conditioning-like state. So it blows air over a wet wound, and that creates cooling of the skin, and so you can create hypothermia. So in order to help it be more effective, what you want to do is put a blanket on the patient, or you could put the plastic right over the patient, then a blanket, and then you'll put the bear hugger over that. But you need a barrier so that there isn't air going directly on the patient's wet open wounds.
Maybe this is a silly question, but when you were talking about a patient is admitted and you can't tell the depth of the burn upon admit always, like 60% of the time, do you only go off of visual assessment, or is there any other way to look like underneath the skin to determine how deep the burn is aside from surgery and time?
Yes, there are. There are these fancy machines that cost somewhere around $200,000 or $300,000. The patient has to lay perfectly still and in position, and they have to hold the position while we roll the machine around and have it hang over the patient, and then we have it assess the depth. It's called laser Doppler imaging. And so we can get a true depth assessment. It's almost 100% accurate. Thermography is something else that I've been looking at that has shown some accuracy levels in the 80 to 90% range. And there's data to support that. But again, there's some user error in that space as well, but a little bit more facile. And then there's things like cyanogreen, where you give or inject something into the vessels. That gives you a coloration that then you measure with another machine, where you have to lay still and you have to give it at the right time and have it all time up the right way, which is really hard for a burn patient, because if you have wounds everywhere, you're going to have to kind of repeat this process for all of the areas. So there are some burn centers who are using laser Doppler kind of aggressively, and they found a system to make it work. But for now, we experts are kind of it for the best assessment in a timely manner.
Thank you.
Mm-hmm.
And then, sorry, we're going to get an echo, Dr. Lewis, but Ashley mentioned someone suggested blue isolation gowns. We have them all over the place in the ED.
Yeah.
Would that be a good option for?
That is. We've also planted some big pieces of plastic sheets down in the ED. Right, Drew? Do you know?
I don't, kind of like the plastic sheets that we have. I know at one point there were some down there. I don't know if they are still there. I will check in with Zoe and some of the other staff down there to see if they're still there. If not, we can pretty easily order another box and get them down.
Yeah. We could also like tube it down pretty quickly, but most of the times when we're coming down, we usually pick up a sheet of plastic on our way because we've always had a challenge with the temperature. And some of it's not your fault. Some of it's that it's a big open room, the trauma bay. It doesn't have radiant heating like our upstairs rooms do. So it's really hard to maintain temperature in those spaces. And traditionally, they're cold, those rooms. So they don't get up to the level of like 90s like our floor is. Great.
I have a question. So you mentioned using urine output to guide resuscitation.
Mm-hmm.
What if the patient, I mean, you have an electrical burn that develops rhabdo, which causes an acute kidney injury?
Mm-hmm.
What are there specific metrics that you guys prefer to guide your resuscitation, such as lactate or CVP, things like that?
So there were studies that were done to look at things like trending CVPs, lactates, and using a pulmonary artery catheter or LIDCO or PICO, and those just haven't been very great. They're great to trend, so we trend in addition to the urine output, and so it gives us information. But if you want to know if you're meeting your resuscitation needs, the kidneys and perfusion and urine are usually the best indicators for now that we have available to us. So it is still the best, even though it's clunky and not sophisticated. Right now, that's the best way. And we use the other data points to help us guide if we're over-resuscitated, still not resuscitating, maybe have cyanide poisoning. Like the lactate in and of itself, we talked about the many things that can impact it. Hypothermia, the burn, cyanide poisoning, So that becomes like a dummy kind of a number. We don't know what's causing the problem. And so urine output is just the better thing. And kidneys are like the litmus paper of the body. They start to fail when something itsy-bitsy starts to go wrong. Great.
Thank you. And then I had another question. So you mentioned, that there is no perfect dressing yet. Are there any products outside or that are used outside the U.S. that are more inexpensive, or are there products that exist that are just too ridiculously expensive that they wouldn't work?
I would say, the thing that I see a lot is people come in with like these burn dressings that are like packs that you can get in like your Walgreens or CVS. And those are good like short term, but they're not good for long-term care for the burn injury. The other thing I see is like toothpaste. That's pretty cheap, but I don't think it feels very good. Sugar is another one, pretty cheap. And it has plus minus. Actually, honey is a good dressing. It has good coverage for Pseudomonas, if anybody wanted to know. And we do use it regularly. And it can debride, enzymatically debride the wound sometimes. So when we think about other dressing types out there, there are a slew of different kinds of wound dressings. And really the most important thing is that it keeps the wound closed, protected, supported, and maybe has some antibacterial agents to prevent or reduce infection. So those are the keys. And if you have something else special and you want to use expensive dressings, you can, but you don't need to. We are a low resource kind of a service. You could get a lot done with some gauze, some Silvadene, and a knife. Okay. Great. Thanks, Alyssa. Any other questions and or thoughts? Anyone out there? I see Courtney Turpin on the line. Do you have anything to add to this?
No, you did great.
Thanks. Did I do it right, Courtney? Do I need to add something else? No. Okay, great. Very good. Well, thank you, everyone, for joining us for the trauma tracer for burn patients. I hope this was helpful and allowed you to at least have a little bit more accessibility to the care for burn patients and why you see the 3 of us burn doctors, now 4, be a little bit persnickety about little things like, what's the temperature? Keep the patient warm. Can we do that? And we just kind of bump in and try to assess the burn wound with you. And go from there. So it will be great to see you guys when I'm down in the ED or other parts of the hospital. Just say hi, and we can go from there. Thank you.